Hi, Steve Dewey, Colorado Springs, Colorado. I'm a consultant AMO, receive royalties from MST, and today we're going to show you the AMO Signature Pro, among other things, using a horizontal chop and an exceptionally dense nucleus. Now, this is a very sweet 93-year-old lady who unfortunately is very deaf and has bilateral hand motion cataracts complicating her macular degeneration. She lives alone in a cabin in remote Colorado, and her daughters were exceptionally concerned. So the same week the Signature Pro arrived, we received the Dewey Horizontal Femto Chopper from Rhine Instruments. Now, its grandfather is the Goldberg side port splitter, which had a very good configuration for wrapping around the equator lens, but required a very large side port incision. So I kept the internal configuration to wrap around the equator of the lens for performing a horizontal chop, but the tip is the same size as the shaft, and this goes into a 23 gauge incision, which provides a beautifully stable, non-leaking side port incision, but unfortunately does require ever so slight enlargement just to get the viscoelastic cannula through. So as is the case with these exceptionally dense cataracts, we're going to use trypan blue to give ourselves good visualization of the capsulotomy. Now I'm doing viscomydriasis here, and I'm really trying to assess how easily I'm going to get it in the Malyugin ring. Yes, an average cataract can be taken out through this size pupil without a lot of difficulty, but with the potential length of this case, the amount of irrigating fluid we're going to put in the eye, the amount of power we're going to use, intraoperative meiosis becomes a big factor, even in a 93-year-old without risk of IFUS. And a Malyugin ring is just so much easier to place prior to performing the capsulotomy. So we're going to use a bent needle cystotome here, and we're going to perform a capsulotomy. And we're not as worried in these really dense cataracts about maintaining the edge of the rexus over the edge of the optic. I think we're going to be fine here. We're going to hydrodissect the lens. We want to have good mobility of the nucleus within the confines of the capsule for the wrapping of the chopper around the equator of the lens. And so I've asked my staff for our weapon of the day, which is a Dewey radius tip. And they have a repackaged needle on the counter, which is the next one in line. We had used the last one 20 cases, and it was time to break this one out. And as I'm looking, I'm realizing this needle isn't a radius tip. It has a sharp edge. Now, a lot of surgeons would advocate that a sharp edge in a dense cataract like this is going to provide an advantage, and I really don't think so. I think it comes down to technique and technology. I will respectfully disagree, and I much prefer the safety of the rounded edge. So I asked them to look again, and in the original packaging, we had a brand new 30-degree straight Packard Dewey radius tip from Microsurgical Technology. And as I'm looking at the exposed amount of needle, I'm realizing that's just not enough. And so I'm going to retract the needle and retract the irrigating sleeve a couple of times, again keeping the irrigation ports parallel to the iris. I don't want to be spraying the endothelium during the case, but that extra length on the exposed bare needle is going to allow for better mechanical leverage as I impale the nucleus and try to manipulate it within the eye. So I push the nucleus away and I apply vacuum and power, and the needle essentially impales itself. The nucleus really kind of brought itself onto the needle, and I'm looking back at the settings, and it was 550 of vacuum, which explains it tremendously. So here we are looking at how the irrigation sleeve will stop the forward progress of the needle, so you don't have to worry about going all the way through. Now I'm pushing the nucleus away to try and provide the most distal positioning of the needle, and I want to wrap around the chopper around the equator of the lens to provide the furthest 2 points away from each other, so they have the best mechanical aspect for performing a chop in these very dense cases. And as I'm watching the case, again in hindsight, the vacuum is pulling this material onto the needle itself, so I'm really not having to push down at all onto the posterior capsule in this case. So again, the chop is performing very well, but it's got a leathery posterior plate. So I've initiated my chop just like I know I should. I've wrapped the two instruments, I pulled them together, and as you separate them though, however, those posterior fibers are just so tough and so leathery, they really don't split, even with the initial posterior manipulation you might attempt. So this is the high definition surgical media center from Abbott Medical Optics. It is the perfect complement to the AMO Signature Pro. What it allows you to do is capture your technique on video and look at the settings in real time on the right. So we've got aspiration, we've got vacuum, we've got power. And when I say look at the technique, I know how I visualize a horizontal chop. This is how it looks. I wrap the chopper around the equator of the lens, I impale the nucleus with the tip of the needle, and I bring the two instruments together and provide a chop. And what I realized as I'm watching this case is that I'm using vacuum to essentially impale the nuclear material, but I'm using the chopper to hold the material stable, because the vacuum is really doing the majority of the work. So as we watch the high levels of vacuum, again up to 550 millimeters of mercury vacuum, we are seeing very low delivery of power. There is no 100% power. Now that's my maximum, but there we saw a little burst at 15. So this is basically fluctuating between foot pedal position 2 and 3, providing small aliquots of this ellipse FX power, which is providing a beautiful emulsification of this material without using continuous power, without using large bursts of power. And so I'm really very pleased. Now I don't know this until retrospect, but that's the beauty. I can watch and see that the settings were perfectly tuned for this particular situation. No chamber instability, no repulsion, no chatter, no turbulence, no stray fragments bouncing off the endothelium. Now, as you watch, you'll see that the nuclear material rotates on the tip of the needle, and that's because the Dewey radius tip doesn't have any sharp edges. Now, the advantage of not having a sharp edge is it doesn't penetrate an intact layer. So it is basically stripping this material off the lamellar structure and emulsifying it beautifully with the application of vacuum and power. So I'm down to that last quadrant, and I'm very, very focused on keeping my power directed posteriorly. I don't want to damage the endothelium in a case this dense, and I'm getting very, very careful about the endothelium, but I missed the capsule, but that's why I'm using the radius tip. So here, I would have captured this capsule even at 200 millimeters of mercury vacuum, but as Dr. Olson's group out in Salt Lake City have demonstrated, you can interact with the capsule, even with a sharp needle, using vacuum, but no power. And so I do prefer to use the rounded needle because the sharp edge can initiate a cut in the posterior capsule. It can shred the posterior capsule if you're applying power at the same time. So I could enlarge the incision and express the nucleus, but at this point in time I really wanted to go ahead and put the posterior chamber lens implant in, preserve the small incision, even though we're not as worried about astigmatism as we are about just a watertight incision. And so you look, and there isn't even a lot of stromal hydration of the incision, which I am exceptionally pleased by in retrospect. So this nuclear fragment on the anterior surface of the lens, we're trying to be very ginger, and we don't want to etch the anterior surface of the lens. Of course, I have a rounded chopper, so that's probably not going to cause any problems. I've got a rounded phaco needle. Again, we're just providing very small bursts of power. We're confining our work to just the very surface of the lens, and this material is just disappearing in the lumen of the needle, and the corneal endothelium was very well preserved. Now, of course, she had edema, but not much considering how long this case was, which in hindsight was 15 minutes. But the amount of power we used was only 123 EFX, which is probably 1/3 of what it would have been with the previous incarnations of this machine. So this lovely 93-year-old, a true champion, a true survivor, is back living in her cabin in remote Colorado. I was delighted to have the chance to help her. Thanks for watching.